For those of you who are watching this video without watching the part 1 of the brain tumor series of mine, please make sure you watch that first before you come in here. There's no point coming and directly listening at how do I diagnose and how do I treat, because that's half the story. It becomes like Abhimanyu, getting into without getting Chakravarti, you wonder what's going on. So today's video, we will talk about what do I do. Does every brain tumor is a cancer? Will every brain tumor has a bad story? Will every brain tumor lead to death or disability? Will every brain tumor need chemotherapy, radiotherapy, this, that, all of those things? And eventually, it sounds like a sad story for anybody who has a brain tumor. For those of you who are thinking like that, it's not true at all. Hi everybody, my name is Dr. Sharan Srinivasan. I am a Stereotactic and Functional Neurosurgeon from Bangalore, India. So this video, we're going to talk about how do I diagnose if patient has subtle symptoms and we suspect maybe it's a brain tumor of some kind. How do I suspect it, and what are the best investigations to do? So what happens is, the common problem we get in places like India today, and I'm quite sure it's the same in many of the countries across the world, is you go with these vague symptoms to a local doctor because he's a family doctor, he's a GP. Sometimes your systems only allow you to go to a GP, does not allow you to go reach out to a specialist like me directly and things like that. So when you go to them, if this GP is not keyed in to understand, the possibility of what a brain tumor entails, what do I do, he will ask for a CT brain plane. CT scan is the commonest first scan of that people know to do, more than MRI today. And many systems don't allow you to do the MRI directly. So they write CT brain plane. Plane means without that injection of contrast. Because injection, this, that, for that you need to get a kidney test done, so many things are there. So, and many people come back with a CT scan report saying CT scan normal. So he'll write some medicine and send the guy. So CT scan normal means no brain tumor? Wrong. With the capital words WRONG. Wrong. You can never say there is nothing in the brain until you give a contrast scan. Okay, that's the next. So you do a CT brain plane and contrast. Now, if there's a tumor somewhere, or whatever all the other things I told you, it will light up with the contrast. Do all tumors light up with contrast? No. What do I do, sir? Why are you complicating the issue so much? I'm not complicating the issue. That is the way our tumors behave. So a high level of suspicion is very important for us. Other problem with the CT of the brain is, we do 10 millimeter sections many times. Between these two 10 millimeter sections, if something is sitting there, the scan will not pick up. So you will actually miss the tumor. So that's also an important thing for us to understand if they are small. Okay, so that's the next thing. So CT scan, brain plane and contrast, no plane and contrast can be a good starting screening test only. Once we do the CT scan and it shows something, then you have to do an MRI. Again, MRI brain plane and contrast. This contrast is very, very important for the tumors to light up, to tell you how big they are, how are they looking, and so on and so forth. You'll see some of the scan images you can see through these videos. You can see how they look. You will have a sense of what is going on. That scan will tell me, number one, how big the tumor is, the location inside the head the tumor is, how critical that location is. Some of them are easier to remove, some of them are not easier to remove surgically. So that will give us some idea how big they are. Is it inside the brain or outside the brain? Is it compressing, the critical vital structures inside the brain, and that can be a problem when we try to operate it and things like that, and so on and so forth. So that is the key. So now, apart from this MRI brain plane and contrast, we have another type of scan which we do for certain specific areas of the brain which are critical areas, called fMRI. So let me tell you a story here of an fMRI. This is a story told to us by a very senior German neurosurgeon called Dr. Maşit Sami, basically a Turkish neurosurgeon who now practices in Hanover in Germany. Now he has a hospital of his which looks like the brain, and that brain stem, what we call, is the entrance to his hospital. His son is also a neurosurgeon. He started operating the year I was born, so you know how old he is now. And he came to one of the conferences in 2016 in Mumbai, and he was telling us the story because fMRI was just sort of picking up at that time. He said the value of fMRI in his practice in managing brain tumors. He said he had a 19-year-old Ukrainian girl who came to him with a tumor in the speaking area of the brain. It's called the Broca's area, B-R-O-C-A-S. Broca's area. Broca's area is the area of the brain that controls spoken speech. And she had a tumor in the Broca's area of her brain. Imagine. But that's not all. Her speech was 100% normal. That means she had no speaking difficulty. Problem. Now the next problem was, her job was she was a foreign language translator for 5 foreign languages. Now here is this one of the best neurosurgeons in the world having to remove a tumor in the speech area of a patient without spoiling her speech. He said, but for this fMRI, I would not have touched her with a barge pole because too risky. So he did an fMRI. fMRI, especially for spoken speech and certain other areas, is quite reliable. It will tell us exactly which area of the brain is doing that function. So it comes in a left inferior frontal lobe area on somewhere in this side of the brain. So he did an fMRI. So normally what should have lit up in the left inferior frontal lobe did not light up. Imagine, no lighting up on fMRI. Lighting up is it looks bright. What lit up was an area of the brain 1 inch lower down, the inferior temporal lobe. What does it mean, sir? What does it mean? Somewhere it lit up? No. No, guys, you have to understand that her brain had healed itself and moved her speech area from here to here. It's like you moving an office from one building to another building because this building is not safe. The brain has done itself happily, without troubling her, without even her knowing. And he said, wow. And he went in and removed this tumor completely with intact speech because that area was not controlling her speech. So the brain also does all these funny things. So many times you need fMRI to know about speech area, especially hand area. These are things that we can define. We also have something called tractographies right now to know the tracks, where they're going and things like that. It is amazing how the right investigation and then reading those investigations, all that makes a difference to know what is going on. Now, brain tumor mimic, I forgot to tell you in the last video, let me say a little bit about that. So many times you'll see something what looks like a brain tumor may not be a brain tumor. So what are you saying? Just now we thought we were getting some sense of it. Again you are correct. There's one serial called Adalat. There's some guy called, I forget his name. K.D. Pathak, his name was. He used to say, Jo dikhta hai, wo hota nahi, wo hota hai, wo dikhta nahi. It's like that. So what looks like a brain tumor may not be a brain tumor. It's a brain tumor because of TB. So you can have TB, not tuberculosis. TB can go to the brain. You can have TB in the brain. So it's like that. So you can have TB anywhere in the brain. So what I'm trying to say is, the MRI scan shows you what looks like a brain tumor. But sometimes you don't know what kind of brain tumor. Cancers, not cancer. Some of them are very clear. We know it's a non-cancerous brain tumor. We know it is a tapeworm larva. Those things we know. But many times you don't know. So we need something called a biopsy. You got the point. You need a biopsy. So before we go down the path of biopsy, now I'm telling you about investigation. Now if you find a tumor in the brain, now your first sense for us as trained neurosurgeons is, does it look like a non-cancerous tumor or a cancerous tumor? 70% of the time we have a reasonable idea what's going on because of the location, the way it looks, the way it lights up on the scan, and things like that, more often than not. So suppose we are not, and so when you have brain tumors, that's how it is. If it is a cancerous brain tumor, for example, just to complete the story. Now there are two kinds of cancers in the brain. One set of cancers are cancers that grow in the brain. The commonest of them is called a glioma. Alright, they grow inside the brain. Now these things maximum grow back in the same area after surgery or spread to adjacent areas, rarely go to other areas unconnected to the brain, but never go to any other part of the body. They never spread outside the brain. Maximum it spreads around the same area, or sometimes goes to areas that is beyond this adjacent area. This is one set of brain tumors which we call as primary brain tumors. The other side of cancerous brain tumors are tumors that come from some other part of the body, like the breast or the abdomen or the lung, things like that. And you know what is interesting? You may be thinking, oh, that is easy to diagnose. No, many of them have no symptoms here. They come with a fit, they come with headache. You see a tumor there, and then they have no other symptom. And many times we thought it was something to do with the brain. You operate, it says this tumor has come from somewhere else in the body. And then you go and search, he's got a stage 3 cancer in his lung. Can you imagine? So guys, it's not easy. Please understand, now it's getting more complicated. We have had so many patients like that. So known cancer patients with a metastasis, we call it metastasis in the brain, or we call it as an occult metastasis, where the primary is unknown. And then we operate and then we start saying, oh, I've got this cancerous tumor, it's spread from, where is the cancer coming from? Then you start hunting. You do a PET scan, you do this, you do that. Sometimes you don't even know where the primary scan is coming. Very frustrating. So that's why I always tell all my boys, the 1 + 1 is never 2 in medicine. But don't think that we're all confused. We have a clear plan. We know how to navigate our way through all this confusion and everything else, and give more than good results for many of our patients. So once we've got a sense of what type of tumor it is, it's a cancerous tumor, non-cancerous tumor, what is that it is, we have to do the question right now all of you are waiting for is, what next? Because all these patients need surgery. So let us go to the treatment aspect of it. So we are assuming that the MRI is done, plain contrast. Sometimes the MR spectroscopy is required, that gets done. If required, a PET scan is done, whatever other scans like a chest X-ray, abdomen, just to rule out something, all that is done. We have an idea, okay, there's a tumor in the brain. So let's deal with the tumors that are non-cancerous first, because that I think is a more exciting part of tumor treatment, which other parts of the body does not have so much of. So if we have a non-cancerous tumor, how do you know it's non-cancerous? Because we know it's coming from the nerve in that location, or what we call as the meningioma, schwannoma, all these, a pituitary adenoma, all these are known non-cancerous tumors, the way they look, the location, and so on and so forth, with reasonable accuracy of more than 95%. So now if these tumors are picked up incidentally, sometimes you had a headache and you do something, or for some other reason you had a head injury, you do that and you see a tumor, many times it happens. Now if these tumors measurements, they take a measurement, all the 3 axes, X, Y, Z axis, and if across all the 3 axes, if the tumor size is less than 3 centimeters, they don't need to be operated immediately. So either if it is very small, sometimes it's 15 mm, 8 mm, 10 mm, small things like a small groundnut, we wait and watch. But they invariably grow. Non-cancerous tumors grow slower, cancerous tumors grow faster. Now, but we don't want especially younger people. So now what we have is, before these kind of treatments came, we had no choice but to wait and watch. So we would do scans every year, see if it's growing, and if it becomes beyond a certain size, then we go out and operate and things like that. So that was very frustrating. The masterly inactivity that we do was not very exciting. Now we have a treatment from radiation called SRS or SRT. That is called stereotactic radiosurgery or stereotactic radiotherapy. SRS is one shot treatment, SRT is 3 to 5 days treatment. Unlike a cancerous radiation where you give radiation 5 days a week for 7 to 8 weeks, here the radiation is only 1 day or maximum 3 to 5 days. So what they do is they can put a focused radiation to that area of the tumor and try to burn it, so that the tumor doesn't become bigger and slowly starts shrinking in size. There are 2 kinds of machines that does that. One is called the gamma knife, which is very expensive. That's the gold standard. Other one is called the Linac machine with SRS facility. Many of the Linacs now have that facility. So you do that. I have enough patients, the tumors have slightly shrunk or don't at least become bigger. It doesn't matter even if it doesn't go away. As long as it doesn't become bigger and sort of dies there, it's okay for us. So that's one aspect. But if there's 30% of them fail SRS or SRT, you can repeat it again after 18 months in one more dose. And it's an outpatient procedure. It's like an MRI scan. You just go in, get the treatment, then go out and go home. Period. That's all it is. It's as easy as that. But there's a cost to it. But suppose it continues to grow and becomes bigger, then we have to operate at points of time. So that's one aspect of it. All right. Sometimes the tumors are in locations we can't operate. So then we have to just keep fingers crossed and try the radiation and then hope for the best. Now, if it comes to a surgery for a non-cancerous brain tumor, the commonest we see is meningioma. There can be meninges, is a covering on the it's like a skin on top of the brain called the dura, and the arachnoid pia. It grows from that dura. It's always a dural based tumor, so it's called the meningioma. The other common brain tumor we see is a schwannoma. I told you, around the nerve sheath, around any nerve in the brain or as much as any other part of the body. The third one is called pituitary adenoma. There's a pituitary gland which is called the master gland just behind the eyes, at the top of the nose. If you go inside, that's where it is sitting. That's called a pituitary adenoma. We have other little less common things called an ependymoma and things like that. But these are the three common things that we see that we operate. So, and if the meningioma is in a location that we can, take off well, enough patients, we take it off completely. And as long as the meningioma does not show any cancerous features, which about 10-15% meningiomas can show, we call them atypical meningiomas or meningopericytoma, hemangiopericytoma. So they can come back. Otherwise, if you excise completely, it is cured. But sometimes we have to leave a little bit behind because it's stuck to a critical area. Then we have to radiate it. Sometimes we burn it. Sometimes it can grow back. So we do serial scans every year for at least 5 years before we tell the patient, I think it looks okay, the tumor is not coming back. So based on the size of the tumor, location of the tumor, the skill sets and the risks to the patient, more often than not, 70-80% of times we can remove it completely with very little collateral damage and patients can get better and they're back to their life. We have enough patients like that. Sometimes, some weakness will come, mild weakness, facial weakness, some, hearing more often than not would have gone, things like that, or, mild imbalance issues and things like that. But there is a risk of surgery, yeah? Please keep that in mind. Any major surgery, heart surgery, brain surgery, 10-15% risk is there. Risk, to life, risk to quality of life, you can have a stroke, you can have loss of speech, you can do all of those things, that's real. As much as you go in any car, there's a risk of accident. You eat any food, you can have food poisoning. You can go in a flight, you can have a flight accident. As theoretical as it is real. It's not zero. But I repeat, those risks are becoming lesser and lesser because of the skills, better skill sets and better technology that we have that support us in this whole endeavor. Now we come to cancerous brain tumors. In cancerous brain tumors, sometimes they're in locations that we can operate, sometimes they're in locations we can't operate, or sometimes they are spread so much it's not worth operating, because we're not able. See, unlike any other part of the body, where you will hear them saying we removed 1 inch more, 1 inch here, 1 inch there of the stomach, just to remove even so-called normal intestine, normal stomach, so that it doesn't spread. I can't do that in the brain. I can't remove 1 inch brain this side, 1 inch brain this side. Sir, sir, this is your brain. I can't do that because every part of the brain has function. So that's our limitation. So it limits us to what we are, or it's like something that is eaten up your brain. So what is there is there, what is not there is not there. So as long as we contain ourselves within that, we don't create any more new damage. So if it's operable, there are enough places where if they give us a good chance, we can, there's 70-80% chance that we can take it off completely. There are enough tools available with us. We have got neuronavigation tools. We got, intraop, dye that we can put through the microscope with magnification. We can see the margins of tumor and we can clearly take out as much as we can. We call it macroscopic or microscopic total excision. It doesn't mean I've got all the tumor out. I have got all the visible tumor out. There will always be invisible tumor sitting somewhere that we can never be able to see. And we assume that is true. Okay. So what do we do next? We wait for the biopsy report to come. Once the biopsy report comes, depending on what the biopsy report is, either we radiate only the tumor area, give radiation, or we try, radiate the whole brain, depending on what we suspect is the grade of the tumor. So the commonest cancerous brain tumor we call as gliomas. So the gliomas have grades 1, 2, 3, 4. 1 and 2 are low grade, 3 and 4 are high grade. So many times 1 and 2 when you are operated, people live for 10-15 years with no problem. 3 and 4 are a little more aggressive. Within 1.5 years to 5 years, many times it comes back, reoperate, and some of them don't live. Most of them don't live beyond 5 years. maximum. So it's like that. So again, a cancerous brain tumor in a good location, we can access microscopic total excision safely. Sometimes what happens is, like I was telling you the story of the speech area, there we have a lot of patients who have such tumors in eloquent areas of the brain, that is in the speech area of the brain with the speech okay, or hand or leg area of the brain. Then what do we do? So in that situation, what do? We do something called awake surgery. So normally if you understand that all these major surgeries we do under general anesthesia. But in many of our patients, every once in a while, we have to keep them awake so that we know which area of the brain we are touching. You know my guitar surgery, that I did. Those of you who don't know, go Google and put Bangalore guitar surgery. You see the story of me my patient playing guitar when I was burning a circuit in the brain. That's also an awake surgery. So here what do we do? That was a simple awake surgery. We just made a 14mm hole in the skull. Here, sometimes the whole surgery, the big surgery we do with the patient completely awake. So then we are talking to him, making him move, asking him questions. And as we are touching areas of the brain, we are checking function. And if you feel that something is getting affected, that much tumor we leave behind. And all this we have discussion with the patient and the family before surgery, making them understand why we do what we do, what is the risk, what is the benefit, how to remove maximum tumor safely without creating a problem for the patient. See, quality of life is as important as removing the tumor. So we have to balance everything at the end of the day. So awake surgery is another, many hospitals are not geared up to do awake surgeries. We are one of those who are able to do those awake surgeries regularly. So it's not a problem. So what I'm trying to make you understand is not a brain tumor, go somewhere, get operated, go home. It's not like that. It is quite complicated. Your post-operative anesthesia has to be very good. Your post-operative care in the ICU has to be very good. Unless all these things happen well, the outcomes need not be great. Minimizing perioperative complications is equally important. So if you manage everything well and based on what the treatment is done, then once the biopsy, so then once whatever we do, suppose the step 3, suppose the patient has a tumor which is an inoperable location, very deep inside the brain, we can't access it and things like that, then we have to do a biopsy at least to know what is going on. So, or we feel that it looks too small, but you can't access it, but you still want to know a biopsy result, then we do something called a stereotactic biopsy. Stereotactic biopsy stereotaxy is a different science. It's a science of trying to access an areas of the brain that you can't see with the with the science. But this can be done with a frame or without a frame. There are two kinds of ways of doing it, at least for brain tumors. That's what we do. So we put a electrode inside with the calculation from the computer. We make a calculation, decide where to put the hole, put the biopsy forceps inside, and biopsy that bit and send for testing directly. Based on what the report shows, we start the treatment. So many times we felt that it doesn't look like a cancerous tumor, not sure what it is. We biopsy it. Many times it turned out to be infection, like a herpes infection. It could be TB infection. It could be some other infection. It's amazing what kind of diagnosis we get. So guys, we are in the world of evidence-based science and evidence-based medicine. So we need evidence. I can't look at your face and say your blood sugar is high. I can't look at your face and say your blood pressure is high. I have to test it. Same way, we have to go in and test it. But because it's deep inside the brain, that itself becomes a minor surgery compared to the biopsy. People stick in a needle as an outpatient and other things. That's not as easy as that. So once whatever we have done, whether we have operated and sent for biopsy, we have done a thing and sent for biopsy, we get the biopsy report. Based on the biopsy report, the next set of treatment starts. Because what is the risk of anything that I do? Will the tumor come back? This is the commonest story patients ask. So what is my answer to that? Yes and no. Again, I'm not giving you a clear answer. Yes, because like I said, even in a non-cancerous tumor, even if I feel that I've accessed completely, there's a theoretical risk of something coming back. So until the day you die, your scan did not show the tumor to come back again, we cannot say you were cured. Please get this. This is the ideal situation. We can say as of today, there is no tumor. What will happen tomorrow, what will happen next year, God only knows. This is the reality. So we have to keep on getting checked, periodically to make sure we are trying to be safe. So based on, the checks, we know what's happening. So we have enough patients with benign tumors, we operated excess completely, 10 years, 15 years, 20 years, living a normal life with no No problem at all.
Bless the Lord, O my soul. O my soul. Worship His holy name. Sing like never before. O my soul. I worship His holy name.
So, that's a lot of confidence. Cancerous brain tumor comes, you're always fighting with the back to the wall, whether it's primary cancer or because of somewhere else. The chemotherapy has its own effects, the radiotherapy has its own effects. But that's something that they have to go through. They have islands of places in between when they do well. Many times they don't do well, it comes back, sometimes they reoperate, and that's what it is. So guys, this is an overview. There's so much more to talk about brain tumors, surgery and everything else. But at the end of the day, we have to be clear that we be aware of the symptoms early, get the right doctor to make a diagnosis, get the right types of scans done, completely not half-hearted, get the right treatment strategy, get the treatment done well, get the treatment done completely, do a good follow-up, and more often than not, we can have a good quality of life as long as we're alive, and many times for many decades to come. Thank you very much.